Hey, welcome everyone to today's presentation on leadership, professionalism, and the evolving practical nursing profession. My name's Kathy Arsenault, and I'm the practice consultant for the Association of New Brunswick Licensed Practical Nurses. Joining me today, we also have Joanne Graham, who is, of course, our Executive Director of ANBLPN, and she and I will both be available at the end of this presentation for the Q&A. If you have any questions that you want to ask at the end, you can just type them in the Q&A box. We'll wait until the end of the presentation to take those questions. And you, of course, have the option to pose your question in the language of your choice. I do want to thank everyone who's joining us today. I've done this presentation quite often to nursing homes especially, but due to the continued interest in this presentation to help optimize scope, we decided to invite all nursing homes in New Brunswick to this webinar so that you can all have the opportunity to hear it and ask questions that pertain to your particular practice environments. During the presentation, I am going to address, some of the many changes that have occurred in practical nursing over the years. And as you all know, there has certainly been a lot. And often when there is a lot of change occurring within a profession, it is met with these mixed emotions. So there's those who are going to, readily embrace these changes, and they're very eager to be working to full scope. But we also have those who are quite reluctant and would rather not take on any new responsibilities. And then, of course, we have those who are stuck in the middle, who just feel a bit confused about all of it and are really left wondering what these changes mean, what are they allowed to do? And that's when we often hear people say things like, well, that's not how we used to do it. So just to get an idea of where you're all at before we get started, I am going to launch a poll question to you all. If you could please just take a moment and answer the poll question when it pops up on your screen. Your responses are anonymous, so you don't have to worry about your name being shown or anything. It's just going to come in as a percentage of how many voted for which option. So I'm just going to launch that to you now. So you should see on your screen, it's just asking, how do you feel about the role optimization that has been occurring for LPNs within your workplace? So are you excited and really happy to be working to your full scope? Are you just a little confused and unsure and you just don't really understand your scope anymore or what you're supposed to be doing? Or are you really unhappy about it and don't think you should be expected to take on any more competencies? So I'll just give you a few seconds to answer that question. So I know some of you are probably attending as a group as well, but if just somebody from the group could maybe respond. So we almost have everybody. So we'll give you about 5 more seconds to respond. Just about 8 of you haven't responded yet. Okay, so I'm just going to share those results with you. So you'll see on your screen about the majority of you, 69% of those who answered are actually excited about it and you're very eager to work to full scope, which is wonderful. And then we have about 31% of you who are just a bit confused and unsure and you just don't really understand your scope anymore, which I think is reasonable. And nobody said they were totally unhappy, so that's great. So I'm just going to take that down off the screen. So often when we are experiencing all of this change, it can lead to issues with our professionalism because, change can be hard. And when things get hard, we get frustrated. And this is when, unfortunately, a lot of people turn to social media to vent their frustrations, or they start acting really unprofessionally in the workplace. So my plan this afternoon is just to talk about some of these changes, the importance of keeping your competencies up to date so that we can all be working to our full scope, and how we can all be displaying leadership and professionalism in our practice. So I'm going to start this presentation just with a brief explanation of the role and the mandate of ANBLPN. There's still often a lot of confusion about this and how regulation gets connected to your practice. So all nursing regulatory bodies have the same mandate, which is protection of the public through the regulatory process. ANBLPN does not function any differently than any other nursing regulatory body. So we fulfill our mandate of public protection in three different ways. The first is through setting those education standards. So we set the education standards for all approved and accredited practical nursing programs in New Brunswick. So in order for you to obtain your practical nursing in New Brunswick, you have to either go to NBCC, CCNB, or Olton College. And the education curriculum in all of these programs are meeting the national scope of practice. And we do that to support labor mobility so that if you relocate anywhere within Canada, you wake up tomorrow and you're moving to Newfoundland or Ontario or Alberta, you are going to meet the entry-level competencies of LPNs, which means you don't need to take additional education and you don't need to write another exam. The second way we fulfill our mandate is through the discipline process. So if a complaint comes in regarding an LPN's practice, we are obligated by law to investigate that complaint to see if there's any confounding evidence to support the claim of unsafe practice. So we do have a complaints committee in place as well as a discipline committee. And based on the evidence that's given to them, they will make the recommendation as to whether or not an LPN's license is suspended or revoked, or they could make the recommendation to dismiss the complaint because there is no supporting evidence to support unsafe practice. And lastly, we set those requirements for annual licensure. So in order for you to maintain your active licensure each year, you have to maintain a minimum of 1,000 active practice hours over the 5 previous years and comply with our annual continuing competence program. So really, in short, the regulatory authorities, we exist to serve the public by promoting good practice, preventing poor practice, and we intervene when practice has become unacceptable. So issues like your wages or your working conditions really fall under the umbrella of your union and not your regulatory authority. So I want to start this presentation by just touching on how much the LPN profession has changed over the last few years, and that with all of these changes has come a lot of added responsibility and the need for leadership in our profession. So the first big change is this prolonged specialized training that we have. So the sheer length of the practical nursing program has changed a lot. So originally, it was a 6-month program. It advanced to 9 months. It was a year for quite a while. Then we had a short period where it was an 18-month certificate program. But ever since 2005, it has been a 2-year college diploma program. So the changes to the length of the program really does reflect that LPNs are now obtaining a lot more knowledge and they have a lot more responsibilities, which is seeing LPNs working more and more to their full scope of practice. And that's why some of us did have to go back and do some of the mandatory upgrading like the med administration and the adult physical assessment course. We did that so that we could ensure that all LPNs in New Brunswick have received the necessary education to be able to work to their full scope of practice. We then, of course, had a title change. So we officially had that name change back in 2002, where we went from being registered nursing assistants to licensed practical nurses. And that was done to support the increasing autonomy of LPNs and to match our counterparts across Canada. Then we have our code of ethics and our standards of practice. So there's been a lot of changes and revisions over the years. Our standards of practice was last revised in 2020. So if you haven't seen the latest edition of the standards of practice, we certainly encourage you to check this out. You can find that right on our website. And our code of ethics is currently under revision right now. ANBLPN has been part of a national working group to revise our code of ethics because the last revision was done back in 2013. So it's been definitely time to revise it. We are anticipating to release the new code of ethics in early 2023. So it should be available to you by end of January, early February 2023. So do keep an eye out for that so that you can replace it with the old code from the old code of ethics. But those revisions are always being done, again, to reflect more leadership, accountability, professionalism within the role of the LPN, and to keep up on different trends like medical assistance in dying, truth and reconciliation, virtual healthcare, some of the, those type of topics. And then our scope of practice and our employer limitations being lifted. I always put these two together because in actuality, your scope of practice as an LPN has actually not changed in several years. It's been the lifting of employer policies that has changed, which is now allowing LPNs to work more to their full scope. And that's why leadership is so pivotal to LPN practice. And I'm going to talk more about that here shortly as we move along. We have our entry-level competencies as well. So that was last revised in 2019. You can also find that document on our website, and we have done a webinar on entry-level competencies as well that you can find on our website. But those were revised to reflect, again, that amount of growth and change that has been occurring within the LPN profession. And then, of course, we have leadership. So we are seeing a lot more leadership from our LPNs. We're seeing LPNs in these more formal leadership roles as well that we would not have seen, 5-10 years ago. And if you review the revised documents that I just mentioned, so our entry-level competencies, our standards of practice, and our coming soon code of ethics, you're going to notice that there's a lot more emphasis on leadership because it is an expectation of all LPNs, and leadership is considered an entry-level competency. So just with those few points, that's a lot of change and growth. And for some of us who've been around for many years, that can be very overwhelming for people. And I do think there's a need to acknowledge that and to understand that some people might require more support than others in regards to those changes. But as a self-regulated professional, we are all required to keep up to date on our competencies and comply with those changes in regulation and employer policy. So we can't just be refusing to take on things that are within our scope of practice. So nursing is, of course, a self-regulated profession, which means that LPNs are responsible for what they do, and they're responsible for what they don't do. And the reason that we self-regulate is to ensure that delivery of safe and competent care that is based on the principles that promote good practice, prevent poor practice, and we intervene when practice is unacceptable. Self-regulation is definitely a privilege, but it also is a responsibility. And what I mean by that responsibility is that we are accountable for our own actions and inactions. So that means that we have to be making appropriate decisions. We're following employer policies, we're following regulatory policies, because that accountability is really inherent to the role of the LPN. And we do this because my practice is my responsibility. I say this a lot in my presentations because I do feel there's a need for people to really become aware that their practice and obligations are not the responsibility of somebody else. So it's not up to your nurse manager, it's not up to your regulatory body, not your team lead, your RN, whatever it is. You are the ones that are responsible for your own practice and meeting your obligations as a self-regulated professional. And I can think a lot of examples from my own practice environment where we see people trying to blame someone else for something that was their own responsibility. So a primary one for me always comes back to our continuing competence program. So don't, leave the meeting or anything when I bring up CTP. But it has been in effect for over 5 years now. And we still have people stating that they've never heard of it. Nobody's ever told them about it, even though we've, blasted that information across every communication medium that we use. But at the end of the day, we ourselves are responsible for ensuring that we're meeting our regulatory requirements and that we're staying informed about what is required of us. So as we're moving along this afternoon, we should really start thinking about, what does a leader look like? What kind of characteristics do they possess? And then you can sort of ask yourself, what is my personal leadership identity? So what I mean by leadership identity, it's really about how you are showing up for work each day. It's your attitude, it's your mental and physical presence. It's, what are your interactions like with others? What is your willingness to take on some of these new challenges? Because if I was able to ask you today if there was people on your team that you admire or maybe you look up to, I'm sure that the answer would be yes. So what is it that you admire about them? Because often it's not their technical skills that you're admiring, it's their interpersonal skills that you admire. And when I was conducting the full leadership session, before COVID took over the world, we had broken into groups to list what kind of characteristics made people a great team player. And every time the majority of things listed were interpersonal skills and not their technical skills. People would always say they're patient, they're a team player, they're a good mentor, they have a positive attitude, they show a lot of empathy, they're compassionate, they're reliable, they're trustworthy, because that's what leadership boils down to. It's not someone's basic ability to put in an IV, but it's going to be their ability of how they're connecting with their clients, that they're having that patience and empathy, that they're team players, that they take part in mentoring. Our technical skills are important and absolutely necessary for us to do our jobs well. But when we think of leadership, it is really more focused on those interpersonal skills. So if you do have somebody like that on your team, you maybe want to start thinking about how you can be that person for somebody else. And I think that a lot of people think that in order to be a leader, you have to have a fancy title after your name of supervisor or manager or director. But really, we can all be leaders in our own practice environment, because being a leader has nothing to do with your title. It's more about how you're conducting yourself in the workplace. And that type of leadership exists in all forms, in all roles, and across all practice environments. So how does this all tie into our standards of practice? So as I said, we do have, more recent standards of practice that were released in 2020 that hopefully everybody has read through, but it has a lot more emphasis on that leadership, professionalism, accountability, because of all the changes that have occurred within the profession. So I just picked out a few to kind of draw your attention to. So the first one is Standard 1, Professional Accountability and Responsibility. And it does state that LPNs are accountable and responsible for their own practice, conduct, and ethical decision-making. So we've already talked about that. The second one states that LPNs provide leadership to support and or participate in mentoring and preceptorship. So again, leadership is listed here because it is part of your role as an LPN. It's expected of LPNs, and it is an entry-level competency. And then Standard 2 is about your evidence-informed practice. And it states that LPNs maintain relevance in practice in response to the changes affecting the profession. So this is a really big one. You have to remain relevant in your own practice to respond to all of these changes. So unfortunately, we do hear from a lot of people who say, well, I'm just going to refuse to do anything more because I didn't sign up for this. Or they'll say things like, well, they don't pay me enough to do this, so I'm not going to do it. And that probably sounds familiar to some people on the line today. That kind of attitude is, of course, the opposite of leadership and professionalism. And we do have to be upfront with people in that you cannot just refuse to do tasks that are within your professional scope and are an expectation of your employment. We need to be working to our full scope and abilities. So what exactly is leadership, and why is there so much talk about it today? So I think that leadership has really become a bit of a buzzword in healthcare lately. So if we were to define leadership, it's really about critical thinking, action, and advocacy. It's about inspiring and motivating others to act in some way to achieve a certain outcome. And it's about demonstrating professional leader behaviors for the purpose of successfully influencing client outcomes. So again, you're going to notice that with those definitions, it doesn't say anything about your title, because we all have the ability to demonstrate these qualities regardless of our role or where we work. So I do want to talk a bit more about how all of these changes have created such a need for leadership development. And I chose this picture because I really think it should be quite evident that LPNs are no longer living in a fishbowl. And the profession has really made a huge jump due to all the changes that have occurred within the profession. And I always like this quote that came out of Nova Scotia that just states that the connection between the need for leadership development is closely tied to the extent of change that has occurred for LPNs. So a few more of those changes are, there's been changes to the LPN Act, there's been changes to our curriculum, our scope of practice and our entry-level competencies, and our standards of practice and our code of ethics. So again, that's a whole lot of change. So as I said before, all of those changes really mean that LPNs are taking on more responsibilities. We're seeing more and more LPNs working in leadership roles that traditionally we would not have seen before. So I do want to look at these points a little bit more closely and what are the changes that have occurred. So this is the LPN Act, or a snippet of it, I should say, that you're seeing on your screen. It's quite long-winded, and after you read it, you're probably left a little bit confused, like I was the first time I read it. So it does define an LPN as a graduate of an approved school of practical nursing who is not a registered nurse in New Brunswick, undertakes the care of patients under the direction and in collaboration with a registered nurse or duly qualified medical practitioner or pharmacist for custodial, convalescent, subacutely ill, and chronically ill patients. So what the heck does that all mean? So our act was amended in 2014, and when that amendment was made, there was two significant changes that occurred. The first big change was that under the people that LPNs work under the direction and in collaboration with, pharmacist was added, and that had not been there before 2014. And this really started to open doors for LPNs, and is why you see LPNs working in pharmacies, you know, giving the flu immunization, of course, giving the COVID immunization over the last few years as well, because LPNs are able to work under the direction and in collaboration with a pharmacist as well. The second really big significant amendment that was made was that under the client population that we care for, subacutely ill was added. And that really opened doors for LPNs, and why you're seeing LPNs working, or you started to see LPNs working more in places like oncology, the emergency room, ICU, because they are educated and competent to care for the subacutely ill as well. So those two amendments really allowed LPNs to practice more autonomously and more to their full scope. Another thing that I always like to pick out with the Act is the part that's underlined there, under the direction and in collaboration with. That does not mean that RNs and LPNs have to be joined at the hip at all times, or as many of you might be able to recall, when I worked at the hospital years ago, it was always that the LPN had to be paired with an RN at all times. And often there's still a lot of confusion about this. It does not mean that we always have to be physically together in the building. It does mean that somebody has to be available to the LPN to consult with and seek clinical guidance, but that could be done via a phone call if, of course, the employer has a policy in place to support that. Because if it did mean that we had to be physically together all the time, we wouldn't be seeing LPNs working in places like the extramural program. Obviously, those LPNs have their independent assignments. They're out in the community seeing their clients. They don't have the RN driving around in the back seat with them. But they, of course, do carry a phone on them so that if they happen upon a situation that, you know, somebody has really taken a turn for the worse, or they feel they're not competent to do something, they can phone back and speak to an RN or a physician or a nurse practitioner, whoever it might be, to seek that clinical guidance. So making those two amendments really did open the doors for LPN practice. Now I want to look at our education curriculum and how much that has changed. So I often refer to it as the big three that I'm just bringing up on your screen here now. So Medication administration was brought into the curriculum in 2004. The year after that, 2005, they brought in the adult physical assessment. And then the phlebotomy and the IV initiation was brought into the curriculum in 2012. So the MedAdmin and the adult physical assessment were the two mandatory upgrades. So any LPN working in New Brunswick has received their MedAdmin training and their adult physical assessment because that was a mandatory upgrade. You had to complete that in order to keep your license. And as much as we groan about them, it really is what makes us more autonomous practitioners and what enhances our leadership abilities. So, full disclosure, I had just graduated, and it was like 3 months after I graduated, I had to go back and do my adult physical assessment. So I was one of those groaners initially, but you do go back and you do those things so that you can stay competent in your practice. But making those changes to the curriculum really does support labor mobility, and it helps you meet those national scope of practice. So again, if you relocate, you're going to meet those minimum practice requirements. And, as healthcare evolves, as it always does, we have to evolve with it. So our practice may need to evolve so that we can keep up to speed with some of these employer policies. And policies need to be updated to reflect those changes as well. So all of those changes, I always say, has led to changes in your personal scope of practice. And I say personal because, as I said earlier, your actual provincial scope of practice has not changed in many years. But your employer policies have changed, which is allowing you to work more to your full scope of practice. So a lot of these things are new to your personal practice, but not new to the LPN scope of practice. And this is where the confusion lies for people, and where people still call us on a weekly basis looking for a task list of who does what. But there is no proverbial task list that we can pull out of the sky, because nursing just cannot be defined by a set of tasks. So it's not like a grocery list where you can just start marking things down. Scope can't be defined that way because scope of practice looks different for everybody, because it's very dependent on when did you graduate, where have you been working, what kind of experiences have you accumulated, have you taken any more education since you last graduated. And we do have a scope of practice document on our website, and it does have a decision-making tool in the back of it as well that I think people would find helpful, and will help you better understand this concept. But essentially, scope can really be broken down into 3 levels. So everybody has their professional scope, which is this yellow circle at the top of your screen there. This defines what we can legally do as regulated health professionals. So if we were to give a simple example, we know that an LPN can't perform surgery and you can't prescribe medications. Legislation is not going to allow you to do that as an LPN. Then we have our individual scope, which is the green circle there. And that is what is dependent on when did you graduate? Where have you been working? What kind of experiences have you accumulated? Have you taken that extra education since you've graduated? So the scope of practice of somebody who graduated in 2018 is going to look very different than someone who maybe graduated in 1996, for example. And then lastly, we have our scope of employment, which is the blue circle. And this is what really has the biggest impact on your practice, because what interventions you perform is going to be really dependent on what your employer is going to allow you to do in that particular workplace. So, on one floor or place, you could be doing phlebotomy, and then in another area, maybe they're not allowing you to do that as an LPN based on employer policy, even though it's something that's within your professional scope of practice and perhaps even your individual scope of practice, because employers do have the right to have their own policies based on the needs of their practice environment. So really, the key to knowing what you can and cannot do really comes down to whether or not you have the education, you're competent, meaning you've done it safely before, and that you're authorized, which means your employer policy. So whenever you're wondering if you can do something, you basically ask 3 questions. One, have I been educated on this? So is that something that I took in my practical nursing program, or I've taken some sort of course since I graduated? The second question is, am I competent? So have I done this, before safely, effectively? I've received that clinical mentorship. And then your third question is, am I authorized? Which means, is there a policy in place here that's going to support me to do this? So those are the 3 questions that your scope of practice can come down to. So I just told you that we don't provide a task list, but now I'm going to give you a little bit of a list, only because we have had so many questions about optimizing the LPN role, especially within the nursing home setting, and so many questions about being in the charge role, that I wanted to give you just sort of a brief rundown of a few of the components that are within the LPN scope of practice that maybe you're not aware of. I don't actually have this slide available in French, but the interpreter is going to read it out in French, so you'll be able to follow along. So legislatively, LPNs can process and initiate orders that are written, verbal, electronic, time-limited, medical directives, stats, PRNs, and telephone orders. They administer medications via all routes, so oral, tube feed, subcutaneous, intramuscular, intradermal, intravenous, topical, vaginal, rectal inhalants. They can conduct narcotic counts, verify MARS, receive medications from pharmacy. They have the ability to phone the physician or the nurse practitioner to request an order. They can phone the pharmacist to verify the medications as well. LPNs can perform phlebotomy. They can initiate IVs, they can pronounce death, they can assume the charge role, they can document on the care plan, collaborate on the initial care plan, of course. The initial care plan does need to be done with the RN, but once that initial collaboration has taken and the care plan has been instituted, LPNs can be performing assessments and documenting on that care plan autonomously. Of course, we're always communicating with everybody on the healthcare team throughout. They can take part in the multidisciplinary meetings that occur, and they can take part in rounds with the physician if necessary. So I want to talk a little bit about the charge role, and I'm sure there'll be questions at the end about this as well. This is probably the biggest question we receive right now, is pertaining to assuming that charge role in long-term care. And I can understand why this is confusing for people. So legislatively, and from our standpoint as a regulator, there's no issue with an LPN assuming the charge role, providing they're competent to do so. It is within your professional scope of practice, and it occurs in, I think, every province throughout Canada. I've recently done a jurisdictional scan on that says, yes, the LPNs are doing this in other provinces. Where it gets sticky is that I do know that the Nursing Home Act currently states that there must be an RN physically in the building at all times. But we know that there are multiple times that does not happen. It's just not possible across our province because of the extreme nursing shortage that we're experiencing. It's just not feasible. So what happens is that the nursing homes do have to report that to social development when they are not able to have an RN in the building. But what I want to stress is that that does not have any effect on the LPN's license. So a lot of LPNs call concerned that something will happen to their license if they're in the building without an RN. You don't have to worry about your license as an LPN. The nursing home themselves, as the employer, may receive an infraction from social development. But as I said before, this is happening on a daily basis across our province, from what we're hearing, because people can't just pull an RN out of thin air, and DONs cannot work 24 hours a day, 7 days a week either. So that's where that collaboration piece has to come in that the employers, if that occurs, that there's no RN in the building, the employer does have to provide you with the name and contact information of who you could call if a situation arose that you felt you weren't competent in something, or you needed to seek some clinical guidance on something. Because again, as per the LPN Act that we just talked about, you always have to have somebody accessible to you, which, as I said, could be done via a telephone call if that is supported in your practice environment. I want to be really clear that I am not suggesting that homes do anything illegal and to just disregard the Nursing Home Act. I just want to let LPNs know that your license is not going to be in jeopardy if you assume the charge role without an RN being in the building. It's up to the employer to report that back to social development. And we do have a fact sheet on this that's available on our website. It's called Working with Limited Resources in Long-Term Care that you could probably find helpful as well. So that really brings us to professionalism and how that ties into your leadership. So when you look at the revisions that have been made to our core regulatory documents, you're going to notice an increased focus, not just on leadership, but on professionalism as well. So nursing professionals study from the science and the art of health because nursing is both a science and an art. And professionalism is realized through those purposeful relationships that we have with our clients and the healthcare team. So if we were going to define professionalism, we could say that it's an overarching term, including your appearance, your behaviors, your competence, and your job role. It's characterized by people who share the same values and a similar education. And it states it's about each person being accountable for their actions. So when we speak of these professional behaviors, it does include our basic manners. And this is often referred to as civility in the professional literature. So the opposite of civility is obviously incivility. And when you go to the research, it mostly focuses on incivility. And after looking at that research, it was really evident that there was certain themes that were really emerging regarding the impact that that incivility has. So I want to show those to you now. So incivility in the workplace has really shown to have a negative impact on staff health. It has a negative impact on your client outcomes, a negative impact on employer concerns, and a negative impact on your workplace environment. And I'm sure that you can all think of a time when somebody's behavior in the workplace has made you, maybe feel bad about yourself, or it's put you in a bad mood, which in turn can come out in some of your client care interactions. So maybe you were a little too sharp with a client, or maybe you disregarded a client because you were frustrated. And that can spread so quickly and lead to a really negative work environment. So that kind of behavior, it can really have a ripple effect amongst the team. So really a reminder of our conduct at work can be simplified into this thought process. Be the nursing professional that you would want to work with or that you would want to be receiving care from. And I think when we stop and we think about it that way, it can really change things for us. And for me, it really makes me stop and reflect on my own behavior or somebody else's, because, we all want work to be a positive place. Nobody wants to be miserable at work, especially since we spend so much time there. And we are definitely in very challenging times right now, which has not been easy for anyone. And I'm sure that all of us have had some sort of a moment because of all that is going on around us right now. But it is because of these challenging times that it's even more essential for us to maintain our professionalism and that we remain civil with each other, because that teamwork is just so vital right now because of all of the challenges that we're facing. So if we talked about incivility, we can talk about civility. And what does it mean to be civil in the workplace? So being civil in the workplace, it's just an awareness of being polite. It does not depend on liking everyone. It requires you to think before you speak, which can be really hard for people. And it might mean that you agree to disagree. And these are all really simple actions that I just read out to you, yet it seems to be the hardest thing for us to do. It does not mean that you have to necessarily go out and have pizza and a beer on a Saturday night with your coworkers all the time. But it does mean that we have to be civil towards each other and that we need to be communicating professionally with each other in the workplace. I can guarantee there are times that you look at the schedule, or maybe you even just drive up to the parking lot and you see who you're going to be working with, and you're either thinking one of two things. You're thinking, oh dear God, I just need to get through this shift. Or you might be thinking the opposite, like, oh, this is excellent. This is the best team ever. You know, somebody could code tonight and we have got this. We're only human. We do not always get along, but we do have to be civil with each other regardless of that. So I really believe that we need to start embracing some of these strategies to improve our professionalism in nursing. And that really includes being civil and polite. So if we each start taking responsibility for our own actions and our reactions, and we all start advocating for change in some small way, then there's going to have to be that shift in increased civility and improve our professionalism in our work environments. So, is this easy and we can just change overnight and become leaders and the epitome of professionalism? Well, of course not. I do want to acknowledge that there are some definite challenges to all of this. We're not so naive to think that this is just an easy switch and everybody's just going to jump on board and they're just going to roll with these changes overnight. So one really significant change is, of course, change fatigue. I really think it is a fair and honest statement to say that in the last 5 to 10 years, LPNs have quite literally been pummeled with some of these new responsibilities. And we acknowledge that, but we also have to be aware that we've been advocating for this moment for a long time as well. We have wanted to see these changes. We have wanted to be working to full scope, which means that we now may have to make some of our own changes now that it is occurring. And as I said at the beginning, some of you are going to embrace those changes and be really gung-ho, and then others are going to need some more time and mentorship to take on some of those challenges. And you can be granted some time, but you cannot outright refuse forever. Another really big challenge to all of this is that we are now working with the largest multi-generational workforce in history. So in any given workplace in New Brunswick today, there could be upwards of 4 different generations working together. So that means that we have 4 generations who have different values regarding work and family life. You have 4 different sets of expectations regarding what's acceptable and unacceptable behavior in the workplace. And I'm sure that you can all think of somebody right now who really tests that. So, I mean, it can be funny to look at these different characteristics of the generations. And I know we can all think of somebody who has really challenged your ethics, your values, perhaps really challenged your patience at times. And that can create a major source of tension for people. And I think that, again, we're only human. We can all admit that we've had moments where we have either thought or said something like, ugh, these millennials, they're just so entitled. Or you might be on the opposite end and be thinking, ugh, these baby boomers, would they just retire already? And the truth is, we react that way because we really and truly don't understand each other, because we have grown up in such different social environments. And that makes us have different values and what we deem as appropriate behavior in the workplace. So research has just repeatedly shown us that workplace stressors and coworkers with different values related to work can really be this battleground for negative reactions. So that means that at times we really do need to pause and remember that just like the role of the LPN has changed, times have changed, and we don't all see things in the same way. And then, of course, we have the challenge of an identity crisis and role confusion. And this is the one, this is my slide of the whole presentation that I think everybody can relate to and have felt one of these 3 ways at some point in their career. All of those changes and expectations that, you know, they can lead to feelings of excitement, feelings of loss, feelings of total confusion. Regardless of what it is, it all involves some kind of change. And sometimes when people feel like they've lost that identity, it drives people to that nostalgic thinking of that, well, that's not how we used to do things, right? So with all of these changes that have occurred, people are left feeling one of 3 ways, like I said at the beginning. So you have on the right side of your screen, you kind of see this evolution of nursing practice from Florence Nightingale to today's nurse. Those are the people who are embracing this evolution of practice. This is a good thing. I'm working more to my full scope. I'm adding competencies to my role. I'm advancing my nursing practice. They've really accepted that. Most people, I think, spend some time like this chaotic, frantic woman in the middle, where it just feel like you have so many roles. You don't know what you're supposed to do first. You're like, I don't even know what I'm doing today. Am I emptying the bedpan or am I giving the meds? Because I have no idea what I'm doing anymore. So I think a lot of people end up there. And then our little meowing cow here on the other end of your screen, those are those apathetic, confused people, our confused cow who, and I'm not calling anybody a cow, it's just an image I found. Those are the people that say, I don't even know what I'm supposed to do anymore, but you know what? It doesn't matter. I'm just going to go to work and put in my time because it doesn't matter anyway. And that is really the most dangerous spot for you to be in. Because that means you've kind of lost your compassion for nursing and your profession when you're in that kind of apathetic mode. We really do aim for everybody to come around to embracing the change and celebrating that evolution of nursing, but it does take time and it can be a real cultural change for people as well. So I do have another poll that I'm going to ask you to answer. Well, I think I do. Hold on. Maybe I didn't launch my second poll. Shoot. No, I don't have a poll for you. Sorry, I was just going to ask how you were feeling now, but maybe we can just talk about it when we do the Q&A. I guess I loaded that poll wrong. Okay, so with all of those changes we just talked about, that's why that leadership and professionalism is, as I said, it's so important to nursing. So research has shown that when we're pairing our leadership and our professionalism, it's going to lead to these more positive client outcomes, which of course that's what we want. We're also going to see healthier work environments when we display leadership and professionalism. I mean, if you think about it, if you have a colleague that just spends all their time complaining at work, they're venting on social media about how awful work is, they're speaking poorly about staff or management or their residents, how does that affect your shift? So obviously it probably leaves you feeling frustrated and you start to feel negative as well, because as I said, that kind of negative attitude really spreads quickly amongst the team, and that incivility just spreads like wildfire. So we do need to try and stand up to all that negativity and start showing some pride and motivation in our practice. When we show leadership and professionalism, it does create pride in the profession and it motivates others to do the same. So for me, the worst thing I hear from other LPNs is when they say things like LPN stands for low paid nurse. This does not show any pride in our profession and it really belittles the profession. So if you're putting that kind of language out there, that is in fact how other people are going to see you. And I don't think that is how we want to be seen. And then lastly, that leadership and professionalism is required in every position across all practice settings. It is not reserved for formal management positions. So as we're finishing here today, I just wanted to leave you with some characteristics of professional presence. So being professionally present requires you to be accountable, ethical, and honest. It's about being respectful in your words and your actions. It's being collaborative with the healthcare team, being clinically competent. So that's about staying up to date on your competencies, having that sense of optimism, which I know is hard these days, showing compassion and empathy towards others. If we are only viewing nursing as a list of tasks that we do run the risk of losing our that compassionate piece of nursing. Using professional language, that has really taken a landslide in recent years, and looking professional. So we need to look and act professional, but we also need to maintain our presence with people as well. So I do want to thank you all for joining me today, and I'm just sharing a screenshot from our website of where you can find some of these resources that I mentioned. If you just visit our website at ANBLPN.ca and you look under the members tab, that's where you're going to click on that practice resources where I just put the green arrow there. That's where you're going to find all of our guidelines, our fact sheets, our position statements, and that can really help you with a lot of questions you might have. We've also done a lot of great webinars on professionalism. We conducted a two-part series on professionalism, and we have one on professionalism and social media as well, which is a whole other topic on its own. And our scope of practice document that I mentioned too, and there's a webinar for that. We record all of our webinars, and then they always get uploaded to our website a couple days following the presentation. So you can always share that with any colleagues that maybe missed out on this one. I am going to open it up for Q&A now. If there are any, you can just use that Q&A box to type in your question, and you can answer your question in the language of your choice. Joanne is here to take on any of the Francophone questions. You always have the option to send your question anonymously as well. If you don't want your name shown, there's a little tick box there that says send anonymously. Is there anything you wanted to add, Joanne, before we look at the Q&A?
No, I'm okay.
So somebody just asked if they're going to have access to the PowerPoint. So as I said, we are recording the presentation, so you can always watch that back or share the link with any of your staff or anything. Wonderful presentation. Thank you. So we're here to take any questions. Oh, here's one. What document shows that LPNs can pronounce death, do care plans, and perform phlebotomy? Well, phlebotomy is part of the PN curriculum, as I said, so that's been ever since 2012. If you graduated prior to 2012, we do have a phlebotomy learning module that you can access through us that gives you the theory, and then it would be up to you to just do your clinical mentorship with your employer, so they can observe you, and they would have their own policies on how many supervised draws are required. We don't set a certain number. We do have a fact sheet or an FAQ on pronouncement of death. So if you just go on our website and look under the members tab and then practice resources, I think sometimes people confuse pronouncing death with certifying death. There is a difference. You're not certifying it. So there's no course for you to pronounce death. Pronouncing death is just you have the ability to show that life has ceased because there are no vital signs. That's basically what pronouncing death is. And then you would follow whatever employer policies are in place when a death occurs at the workplace. And we have a document on care plans as well. So again, just go to practice resources and it talks about care planning and that it is within your scope. Is there an amount or a limit of patients or residents that we administer medication to in a round of MedPass? So Joanne, you probably get that question a lot. If you want to speak to that, I can say that we don't set a set number. That's not something that the regulator would do. It would be up to you to have those conversations with your employer if you feel that something is becoming unsafe. Those are conversations to have in-house. Did you have anything extra to add to that one, Joanne?
No, you've answered it all. Thank you.
I'll just give you another minute or two if you want to ask a question. And as I said, you always have the ability to send anonymously. What are our rights to refuse to participate in procedures or administer medicine injections that do not align with our personal beliefs, for example, MAID? So sometimes there is like ethical objections to that. We do have a document. I guess we kind of speak to that a bit when in our cannabis document. I know it's not the same topic, but it's the same idea. Some people might be morally opposed to maybe administering cannabis as a medication, for example. You can't just abandon your client. You do, again, have to have this conversation with your nurse manager if you're morally opposed to something. You can't voice that to the client who has chosen it, of course, because they have the right to choose their treatment plan. But you have to be able to then transfer care over to somebody else. So there can't be any break in that care. But those are, you know, private professional conversations you have to have with management around more like being morally or ethically opposed to a line of treatment. So here's one to talk about, Joanne. In the Nursing Home Act, it stipulates that a registered nurse should always be on site. Do you see the act change in the future to include LPNs or RN must be present 24/7? So I know, Joanne, you've had some meetings regarding that.
We know is that that's a stipulation with the social development. And I know that there is conversations in the hope that the Nursing Home Act will be revised in the very near future, not knowing what the changes will be. So it's hard to say. I know that there's been a lot of calls and comments on my part that people do call, but we haven't, there's nothing definite as of yet. All we know is that sometimes there are homes that do put the LPNs in the in-charge role. And there are more rural homes that certainly have RNs that are on call for them to be able to collaborate with if the LPN needs to. So we always respond that they need to contact the RN that is on call. If the RN is not answering, then to please call the director of care. And then there is also the administrator, and we've also responded that 911 is readily available if need be as well in some of the conversations that we've had. But I know that they are looking at the Nursing Home Act at this time.
We do have that document on our website about working with limited resources in long-term care that speaks to that as well. So you can just find that under practice resources, and it's one of our FAQs. Just as a follow-up, just a thank you for that response. So if there aren't any more questions, we'll just thank everybody for joining us today. If you do think of a question later, you can, of course, reach out to us anytime. Our contact information is available on the website as well. If you just look under the About tab, you'll see our number as well as our corresponding email addresses if you want to follow up later. All right. So thanks so much for joining us today. And thank you, of course, to all the great work that you guys are doing under very challenging circumstances for sure. We hope you all get some time over the holiday season to rest and relax with your family and friends. So we wish you all happy holidays and all the best in 2023. Thank you.